Welcome to the Shockwave Therapy podcast. My name is James Woolwich, osteopath and clinical director at the Abbeyfields Clinic in Suffolk. We will be trying to demystify the concept of shockwave treatment whilst bringing together experts in their field to discuss the latest research. If you are deciding on whether to add this modality into your clinic or just improve the way you deliver it, then we hope this is the podcast for you. Today we will be talking to Dr Carlo Di Maio. He's an orthopaedic surgeon from Germany. He's been using shockwave therapy, both focused and radial, since 2002. He's an international lecturer on the subject and authored a number of books on the subject as well. He's helped develop some of the handpiece applicators for Storz Medical. He uses it in collaboration with a number of other therapeutic techniques involving osteopathy, injection therapy, acupuncture, fascial distortion therapy as well. So he has a number of modalities at his disposal, and what we're going to try and get to today is his decision-making process on how he uses, when he uses shockwave and the various types. So welcome, Carlo. We're just going to kick straight off, and just for everyone listening, if you could just give us a quick history of your use of shockwave and your journey so far, please.
Yeah. I'm a German orthopedic surgeon, and I left in 2002 my hospital. I finished my hospital career and joined my friend and partner Stefan Swart in his existing orthopedic practice. And in the early 2000s in Germany was a big hype about focused shockwaves, and the private insurances paid a lot of money, about 400 Deutschmark per treatment, for the treatment of heel spur, Achilles tendinopathy, and tennis elbow. And so we started in 2002 with a rented device. Once a month, we treated the patients in the mentioned indications, and had good results for 2 or 3 years, about 50-60%.
And that was Carlo, that was with a focused device only?
Absolutely. We started with a focused device in Germany because during this time we had no radial devices. We only had the focused device, and in the beginning, in the late 80s, they started treating the kidney stones. And in the mid-90s, some colleagues had good results with non-healing fractures and the tendinopathies, and so there was a real big hype about this issue, and a lot of colleagues earned a lot of money with this kind of treatment. And so we started directly from the beginning of my practice career with one focused device, and we didn't apply the shockwaves on our own. We had a nice colleague. She brought the device into our practice, and we marked with a pen the spots and located this with ultrasound, and then she treated the patients 2,000 shots once a month, 3 times, and it worked. We had about 50% good results.
Okay.
And that was our first contact with the shockwaves, and we never thought about the real things around, because we only got the indication, marked the place, and went away. And that was our start with the shockwave.
So when did you get your radial device then, Carlo?
First we bought one focused device in 2005, and had also good experiences with patellar tendinopathy and great trochanter pain syndrome. And during this period, we learned a lot about trigger points, acupuncture, manual medicine, and osteopathy. And in 2008 or 2009, we bought 2 radial devices.
Okay.
And the magic moment for us was when we learned the trigger point therapy. And it was during our acupuncture studies. It was not a typical course for shockwaves. We had no courses or lectures in Germany about those topics. And we tried to treat the trigger points with the radial devices, and then after some month, we combined both. And so first the focused, and then the trigger point treatment. And it was magic because from this moment on, we had 80% good results. Yeah? And it was really, really impressive.
And that was the only variable that you changed. It wasn't that you were getting better at it. It wasn't that you were adding other things into it. It simply was, as far as you could tell, the addition of using radial on the surrounding fascial system and trigger points.
And especially the trigger points, because the fascial system was not so present at this time. Yeah? We didn't know a lot about those topics. We only treated the trigger points. I love manual medicine, chiropractic and so on. And surely you need the right diagnosis and take care of other orthopedic factors, bone length, foot structures, and those things are very important for me. And so it was absolutely impressive when I started to combine the trigger points with the focus device. And in our daily practice, the trigger point therapy is about 70% of my daily work. It's not typical, the whole combination. Later on, we studied the FDM according to Stephen Tupaldus. That was also magic because we learned a lot about the fascia.
And that, sorry, Carlo, just to interrupt, because I know we taught last weekend together, so it was the first time I'd heard that acronym, which is FDM, so I had to go away research that a little bit because I didn't know too much. So that, for everyone who's listening, that's the fascial distortion model by an American osteopath who's now since departed, and he devised a sort of modelled way of looking at fascial distortions, didn't he?
Really simple. Very simple model, and all of our other topics are included. The trigger points, the insertion tendinopathies, but it's really holistic and for us really practical. I love simple models, and it's really simple to apply it in your daily practice.
Right, and when you have a patient with a normal tendinopathy, because the vast majority of people use Shockwave for tendinopathies as it stands. So would your approach be to treat the tendon first, the fascial chains afterwards? Do you have a sort of a way of approaching the fascia first, then the tendon, or does it change from patient to patient?
No, it changes sometimes during the treatment. For example, the best example is the heel spur or the Achilles tendinopathy. You always find some hypomobilization in the lower ankle, in the knee, and in the hip area. So mostly I start with mobilization manually, those joints, a foot, ankle, sometimes knee and hip and iliosacral joint. Then logically I treat the fascia, because when you treat the fascia with your Shockwave devices and the special applicators, you use no gel.
You don't use any gel?
When I treat the fascia, never. No
and
gel.
That's with, so to, also for everyone listening, I know you have Storz devices, so you're using the radial head, and you might use the D20 even, or the big ones, and you.
That's one of the trigger point, or the classical applicators. We use the fascia set.
Yes, of course.
It's a special kind of applicators.
Yeah.
And it's more sliding over the fascia, the tissue. And,
yes, I understand.
If you use gel, you slide over and
sure.
have no contact. You need deep contact to the tissue.
Yes.
So many of the podiatrists use some manual devices, some sliders, some blades,
Yes.
But it's the same effect if you use our Shockwave devices you use the radial ballistic transmitter and apply a special fascia applicator.
And you're being very humble at this point, Carlo. I should point out to the audience that you helped develop these instruments, didn't you, on fascial work?
Okay.
So
that's true.
I'll fill that
because,
bit in.
After our study of the facial distortion model, it was very, very difficult to apply it in your daily practice, because especially the thumb is so affected and injured by those aggressive kind of treatment.
Your hands will wear out.
Absolutely, and it was not practical. After 2 months, I have ruptures in the skin, and you use the whole day lot of disinfection and use it on your hands, because after every treatment you have to put some disinfection on your hands. And so if you have those ruptures, especially on the tip of your fingers, according to the slice of over the tissue, it's painful and you can't apply it anymore. And so we spoke with Storz and developed 4 typical applicators to make it more easy to treat those fascial systems. And you use no gel, you need a deep contact to the tissue. And so first step is absolutely perfect correction of the blockades and the chiropractic things. It's my first approach. Then proper positioning of the patient on the prone position with some half rows, so that you have the possibility to apply deep contact. And then I treat the fascia, first the plantar fascia, then the gastrocnemius area, hamstrings, lateral, and sometimes the gluteal fascia if necessary. And typically, you asked me before, after 2 or 3 treatments, the fascia is done. There are no adhesions anymore.
And do the patients report back to you a sense of change in stiffness or?
It's a burning pain. It feels like you're putting the hair, putting it out, and it's really painful, but only in some special areas where the fascia is adherent. You have some patients, first treatment you slide over the skin and is no fascial problem, and so.
But what do they say to you the week or 2 weeks afterwards? Do they report back that they feel looser, or do they, as part of a general, it's reducing their pain in the Achilles?
Absolutely, it's after the treatment. Usually, you have a referred pain and a lasting pain for 1-2 days. But after the treatment of the fascial problems, I treat the trigger points. And in the end, the tendinopathy with the focus device.
All in one session?
In one session.
Okay.
Because, for example, the fascia treatment lasts not longer than 2 or 3 minutes maximum. And also the trigger point treatment, 5, 6, 7 minutes. I only treat 4 or 5 important trigger points, not the satellite points. It's not necessary. I treat 1 point with maximum 1,000 pulses, and so it lasts 4, 5, 6 minutes. And so you have now 8 minutes of treatment, and afterwards 7-8 minutes of focused shockwave treatment with a maximum 2,000 pulses. That's my concept, and it's always the same concept with any.
And do you use the radial ballistic device for the trigger points?
For the fascia,
for the trigger points
and
themselves,
the trigger points too.
Do you what guides your? Do you keep the? Because some people get a bit confused about this. Do you keep the radial device on the trigger point until the patient reports that their pain has gone?
Absolutely, that's my way of treatment. A 90-degree, enough of gel, medium pressure. I feel. If you're experienced in the trigger point treatment, you feel the point, and sometimes I use a tapestry roll to roll over the tissue, and you feel the bump of the muscle. And but if you use the applicator in a correct manner, you can feel the trigger points. I stay on it, but if you have no release or a relief after 1,000 shots. With medium energy, I like to treat in between 1.5 bar and maximum 3.5 bar. It depends on the person. If you have an athlete, a rugby player, you can start with 3 bar. If you have a female teacher, slim person, start with 1.2, 1.3, but you need to apply enough energy. And in the end, I 90-degree angle on the spot, deep contact, and then maximum 1,000 pulses. Usually after 4 and 6 up to 600 pulses, you get the feedback that the pain is gone, usually.
Sure. Okay. Yeah. And what would be in terms of the applicators for using normal shockwave with a radial, what would be the 2 or 3 applicators you use day in, day out?
Day in, day out, my favorite applicator is the D20. There's a feather inside, you have a huge range of motion, it fans out a little bit, and it's very suitable for the muscles, if you have some flesh under your applicator.
Sure.
And if you treat smaller areas, hand, elbow, I use the R15.
Right.
Yeah. And if you treat the glutes or the upper leg, I prefer, on the one hand, the 35 applicator, the big one. Yeah, I don't know the right term.
Yes.
And deep impact is also very, very important if you have no focus device, because the penetration depth of any applicator is absolutely different.
Yes.
And maximum 4 or 5 centimeters is the end of the reachable energy.
That's the gold-tipped DI-15, isn't it, I think?
Absolutely. The gold tip is for if you don't have access to a focus device. It's a best tool for deep tissue. But in my daily practice, I can't work without the focused one, because if you treat small muscles in the neck or the craniomandibular joint, it's excellent to treat the complex area here with a focused device, low energy levels. It's amazing because it's pain-free and it's anti-inflammatory. It's a wonder, because the pain is really, really acceptable, and you can treat also in the neck with a focus device, and it's really difficult to treat those areas with radial devices. It's possible.
Sure.
You have the white plastic tip, but I think the energy applied by the focus device in some areas is uncomparable to the radial devices.
I think you described it as the magic, when the magic happens last week.
Yeah, it's for me, it's magic, because when we started to treat different indications with a focus one, not only tendinopathies, 70 years tendinopathy, it's impressive. But I had a patient who was injured by a horse and had a black spot on his foot for 6 months. Yeah, It was a necrosis.
Right.
And he came to me with another indication. He had some knee injury, and he showed me this black necrotic spot. It was like a 2 or 3 centimeter diameter, and I treated it 3 times, only applied the focus device 2,000 shots, and after the 4th treatment, it fell off, and underneath was perfect skin. You saw no scar, nothing. And it lasted for 6 months or longer. And if you see those things, you never lose the magic. Yeah? If you have rhizarthrosis, it's difficult. But if you treat the fascial areas on the lower arm, on the hand, the thumb, the small muscles with the radial device, and in the end you apply 1,000 shots of a focus device, low energy, 0.057 as accepted. Yeah, you have 50-60% of chronic arthrosis really, really released. You can see it in the ultrasound, and the patient demands it after 2 or 3 months. Doctor, I need 2 or 3 treatments again, and I have so experienced patients. I apply the device, give it to the other hand, and I leave the room, and he treats himself over the spot. It's simple, 1,000 shots. And
so this would be after over arthritic thumb joints and hand joints.
Absolutely, thumb and all small joints you can treat perfect with the focus device, and it takes 2 or 3 months sometimes, but we treat it a lot, especially the thumb, because the surgical treatment is really difficult, and the results are not always very, very.
I know lots of people use the focus device for arthritic changes in the feet, large toe and so forth, and I've started doing that with my foot surgeon here, and we've seen some reasonably good results with it, I have to say. But when I think, like all of the things that we use Shockwave for, it's when we know what other options that patient has, which are either surgical or steroid injection or more analgesia. So why wouldn't you at least try using Shockwave before you go to those other more invasive or unpleasant options?
Absolutely. There are no side effects, no risk, and it's absolutely impressive when you see the results after some weeks. And it's not in 100% of your patients, but it's any other therapy you have similar results. But if you combine the focused device with other treatment options, manual therapy, I love to inject PRP, activated plasma, in elbow and sometimes also in infected joints. It's a perfect combination.
So you would inject, and then you would Shockwave immediately after?
Immediately after. Friends of mine from Munich do it in 1 week. They treat the elbow with a PRP, and the next week they apply the Shockwaves. But for me, it's simple. I apply 2 milliliters of plasma directly, ultrasound guided into the lesion, and then I apply 2,000 low-level focused shots add-on, and have excellent results in every tendon problem. This is more severe than and if you have some ruptures in the tendon, I usually start directly with this combination protocol.
Right. Okay. So I mean that's really interesting, because a lot of people would see in certainly in this country, you get this sense that you get all the sports doctors on one side of the fence that say, we only inject PRPs, there's no evidence for Shockwave, and then you get lots of people over the other side of the fence saying Shockwave is the answer, you don't want to be sticking injections into anybody if you can help it. But actually in really chronic, you're saying in really chronic, hard to get better cases, the combination of both works, right?
Absolutely. But for sure, we have to conduct more studies. It's more experience, but we never had any infection with a PRP injection. And so there are so many hints that it works perfect together. So I tried, and many of our colleagues with high performing athletes use it to treat those kind of patients. And for me, it's the perfect combination, because for more than 10 years, I love to treat more a biological and natural way, and not to treat with steroids if it's not necessary, or analgetics. It's only a symptomatic treatment, and we want to recover the tissue. That's our main goal.
And when we were talking as well, which I was greatly encouraged by, because again, you'd usually get, if you were used to speaking to an orthopaedic surgeon in a normal historical sense, they wouldn't be as holistic as you, I would have to say, in my experience. So when you're dealing with patients with chronic tendinopathies or soft tissue based pain, you're also keen on supporting that in a number of other ways. From a metabolic point of view, I know we've got lots of evidence now about metabolic syndrome and how that underpins quite a lot of tendinopathies. So what kind of general advice do you give to support patients when you're treating their tendons?
That's a really important issue, because I think our way of life is not good. We will walk in a really wrong direction. The sugar consumption over the last 100 years increased 10 times.
Wow.
And so I think one of the main problems is the sugar, and the carbohydrate consumption. So you get an over-acidification in the metabolic system because the sugar molecules destroy your proteins, and the whole metabolic syndrome depends on the carbohydrates. Yeah? Mm-hmm. So in the end, it has to be really simple to apply it in your daily life. And so the patients ask me, what can I do? I say, sleep enough, eat more vegetable, and I like meat. I'm not a vegetarian or something like that.
Sure.
And it's but I think the sugar consumption is our main issue.
Yes.
And it's all those patients on the 1 week they have problem on the left side, next week on the other side, 2 weeks later the left elbow, right elbow, and you feel deep in your soul that you're only treating the symptoms.
Yes.
Yeah, and so gout is a problem, but it also depends on the metabolic system. And if you reduce the sugar, the gout is gone. Yeah, and so that's, for me, it's really important to discuss those topics. And for 3 or 4 months, we made some DNA testing. Mm-hmm. It's really interesting, but I have a colleague in Munich, and I take the blood samples, and he discusses with the patients the solution, because it's so complicated that I lose time for my daily work, and I'm more manual, and I want to treat my patients with things we spoke about, and not to discuss for a long time the metabolic systems. But the basics are simple: paleo associated sugar reduction, sports. I like HIIT training, and workout, and I inform my patients when they do a lot of marathon runs or long-term sports. It's also a problem for the metabolic system, because they think I do a good thing, but also, if you do a lot of long-term sports, you have an over-acidification too. And so you find a good combination between all those things, and it must be suitable for your daily life.
Okay.
And those are my
How do you, with the other big contribution to some of the tendinopathies are hormones in terms of the menopause. How do you simply give advice on some of those patients that you see where you think there's a hormonal input?
Oh, that's sometimes it's a little difficult. I go first for the cholesterol and vitamin A, D, E, and K. I think also the vitamin D is a hormone too, and I don't care a lot about sexual hormones. Sometimes it's a problem, but if I see a severe problem in this system, I speak with my colleagues, and they clear and fix those problems, because it's really, if you start treating the metabolic and hormonal system, it's really difficult, and it's not my special theme, and it's really complicated, especially if you treat female patients with those topics.
Okay. So I think that's covered most of the things that we had outlined on the questions before. I think that the only thing that I wanted to just talk about briefly, because I think people on the podcast are getting used to me talking about tendons and plantar fasciitis and general things, but your work that you did last week on headaches and the transmitter you've developed, which is called the Atlas transmitter. Can you just talk about how, because I think when we started teaching this a couple of years ago, we were still under the impression, for instance, that shockwave could be potentially quite harmful and you couldn't use it on the lungs and so on and so forth. Here are experts like yourself having used shockwave for 17, 18 years, and you're using focused shockwave on the jaw joint, and you're using it on the neck and so forth. So with someone with a generalized neck-related headache, what would be a general approach, if we could be general? I know everyone's specific, but...
Those things are daily practice for us because, although we have not only typical tendinopathies, we have typical orthopedic patient in our practice, and so headache and neck pain are related, I think so. Shoulder, neck, and headache. And so first I go for the atlas joint. For me it's very important to check if there's a heavy problem, typically on the left side, and I fix it manually, and then I treat the trigger points in the neck, shoulder, arm, and sometimes I combine it with acupuncture. Then
would that be all with your fascial applicators or with just the normal radial head?
Yeah. If it's necessary, you feel it with your thumb. If you slide over the neck and you feel severe adhesions in those regions, I treat it with the fascial applicators in the sitting position and in a prone lying position. And the next step is to treat the trigger points of the neck, especially. Sometimes also the vertebra, the thoracic vertebra is important, especially TH3, 4, and 5. Yeah? And you have to look if there are some problems in the shoulder blade, as it's really complicated sometimes. And when you treat it for the first time, we talk about headache, take care of those regions, especially the levator scapula, rhomboid, and costotransversal joints are also very important. And during this time, for example, in a prone position, I apply some acupuncture needles in the neck.
Okay, while you're treating the other areas with the shockwave.
The other areas, and then I put them out and treat, if necessary, with a focus device, the trigger points in the neck. And if you have a severe blockade on the atlas, for example, on the left side, I use my atlas transmitter with 8 Hertz, low level of energy, and can feel the energy transducting through the atlas on the other side with my other finger on the other side.
And is your hope, your aim there, is that from a neurological suppressive point of view, as in pain gate? You're trying to create a vibration through that area, which ultimately pain gates the symptoms traveling.
Yeah.
Okay.
That's the idea, and it's not pain. It's not harmful. It's not painful.
Sure.
And sometimes I use some impulse. I mobilize it in the end.
Right.
If it's necessary, because there are many studies out there that the impulse is sometimes important. And so I try it on the soft way, and if it's not possible and you feel that there's a hypomobility, I mobilize it very, very softly with the hanging technique, and I let the patient increase his shoulders, hold the neck, and then they let fall down the shoulders, and they mobilize themselves. It's absolutely pain-free, and it's a nice technique. And also, as mentioned before, I take care for the craniomandibular joints in those cases.
Right.
If you have longer-lasting problems on the atlas and headache, you find on the same side some problems in the craniomandibular joint, and so I take care for this joint and treat it as mentioned before. Yeah.
And as those of us that are lucky enough, I don't have as many machines as you, but I have one focus device, and I know that everyone says the same. It's incredibly effective at reproducing the patient's pain, isn't it? And I've not started using it on the head and neck, but do you, when you're say putting it on the temporomandibular joint, and so do you get the patient feeding back that's the pain traveling into the head that they get, and so on and so forth?
That's an important point. The pain, if you treat the right point, the patient tells you that this is the cause of your pain. It's absolutely true what you're saying.
Yeah.
Because if you apply the focus device on the right spot on the temporomandibular joint, especially on the temporalis here upside, and then you have the right spot, and the patient tells you, yes, this is the cause of my headache.
Right.
And if you have no focus device, you can use the R15 sometimes.
Yeah.
It's possible especially on the temporal area.
Yeah.
And but directly over the joint, it's absolutely perfect to use the focus device with a long standoff.
Yes.
And low levels of energy. You don't need high levels. I use typically 0.05, 0.07, and you can cause the pain exactly on a millimeter spot.
Yes.
And if you want, you can use it if you have a low back pain, for example. And you're not sure, is it the facet joint?
Yeah.
Is it the muscle? And if you treat with the focus device, you slide over the back, and the patient tells you, yes, you found my pain spot, and then you can treat it again.
Because you mentioned in that talk last week that you use it as almost a scanning device. And in sometimes actually indeed you've used it to find a fracture or something like that.
Yeah. If you have a hip replacement and you're not sure, there's a little bit of mobility, especially in the femoral part. You use your focus device and try it on the other side and increase the energy up to the level when the patient mentioned a small pain, only a slight pain. And then you change the side where the replacement is. And if you have a really big pain, a strong pain, you know there's something wrong with this replacement. It's simple. And also if you have possibly prolapse of the disc, try to drive over move over the lower back part, and you can typically affect the nerve and apply the pain.
Right.
And the patient tells you, yes, this is my spot, and it's really impressive. If you have an edema on the foot, and I have a lot of patients coming to my practice and say, oh, I have pain under the foot. So you make your ultrasound device, and you're not sure, is it a heel spur, is it a tendinopathy, but you see nothing on the X-ray. Use your focus device, slide over the foot, and if you have the metatarsal area, cuneiform, cuboid or something like that, typical pain in low energy levels, it's more an edema or a fracture than tendinopathy. Is really effective to differentiate between the different causes of pain.
Right. Okay, that's interesting. I've not heard that until last week, but I certainly think I knew about the idea of reproducing their pain, which I think is very therapeutic. If a patient knows you found, certainly one of the main origins of their pain, I think that's
great. They tell you directly, yes, you found it. That's my typical pain.
Yeah.
And I had patients. They were in hospital because of their strong muscular low back pain, especially if you have a complex problem in the iliosacral joint. You have cramps in the muscles. It's incredible. And no morphines, no painkillers work. And if you treat those patients accurately on the trigger points, especially the deep trigger points of the piriformis gemelli, directly compressing the ischiatic nerve, you have wonderful results. Wonderful, because those patients had injections, and if you treat muscular problems with steroids, you increase the problem.
Yes.
Because it's the wrong and absolutely wrong way. And for me, I tell all my patients, if they have some unspecific back pain, I don't like this term, but it's 80%. I tell them, okay, you have no nerve injury. You have no pain over the ischiatic nerve. You have no LASIK positive test or something. First, I treat your iliosacral joints, your trigger points. Sometimes I inject some muscle relaxants at the facet joints to reduce a little bit the nerval strengthness. But in 80-90%, if you treat them right, 2 sessions a week, the pain is gone after 1 week. And only those patients with a lasting pain, especially you have your pain in the iliosacral joint, sometimes a small disc injury may be the cause of this muscular pain. It's the beginning of a disc problem.
Sure.
And so I tell my patients, first we treat the things that are hands-on, and if they last, we can make an X-ray, we can do an MRI. But in 90%, if you treat them right, especially if the pain is only lasts for 2 or 3 days, it's wonderful. And in those cases, I need the focus device for the deep muscles because you can't reach them with the other devices.
Sure.
But as a tip, if you have no focus device and you know a little bit about acupuncture, I have 20 centimeter needles and they work well if you apply them on the deep muscles, if you don't have access to the focus device, because it's not cheap, you know.
No, I know. Yes. Well, it's getting a little bit better value, and I think that people are now starting to ask me more questions about whether they should get a focus device. And
I highly recommend if you really make your experience with the radial device and you learn more about it. You need the focused one if it's possible, because in daily practice, 70% we treat simple trigger point problems with the radial device, because most of my patients come to my practice with simple neck and low back problems. They, not everyone needs a focus device. We have 10-20% of tendinopathies. We have the huge spectrum, the whole spectrum of orthopedic patients. But in my daily practice, I use the radial device for most of my orthopedic patients. If you have a knee pain, if you have a meniscal injury, you have a lot of trigger points in the gemelli muscles and the semitendinosus, semimembranosus. I treat them and they get their injections. Sometimes we make a lot of therapy. In those cases, if it's not too severe, we combine it with a PRP. And so in the end, I treat the medial menisc with 1,000 or 1,500 shots focused, and the trigger points and the fascia in the surrounding area. And it's if you have the possibility to use all those devices in your daily practice, you can treat a lot of trigger points with simple shots of radial device. It's not so complicated in my daily practice.
Okay.
So I combine it with everything else.
Well, I think that's covered everything I wanted to speak to you to do about today, and I think I've certainly learned a lot from last week, and I've got my brain ticking about ideas that I wouldn't have thought. But it's inspiring in a way, because having an orthopedic surgeon that's used it for so long and used it so regularly from day to day, you know, your anecdotal experience in your case is really very strong. Whereas obviously, you know, that the gold standard should be, we should have RCTs, we should, you know, but ultimately I think that Shockwave is still quite a new thing, especially us at our level using focus Shockwave. So being able to use you as a resource to say, look, this is possible, very low energy on the jaw joint, on the neck, using a radial device with a different applicator, which Storts are good at doing their development on. So it's just treating a wider range of conditions now, rather than just the classic 5 or 6 that we see over here.
More and more.
That's actually the one thing I'm starting to pursue, and I'm hoping that when people listen to this, they'll get a bit of confidence from the fact that they're hearing you speaking about this, saying, actually, it's possible. Why wouldn't you try? And I think, as I said before, and when I taught last week, the thing that I always found so easy with Shockwave is the simple question you always ask is, well, this person, why not? Yes, why wouldn't you, when you know the choices available are not very nice? So
Absolutely.
You know,
it's I love simple things.
Yes,
I love simple things, and it's a no-brainer. You don't have to think a lot about any side effects. You don't treat acute inflammation or a tumor or someone with an acute rheumatic disease. It's stupid. But most of our patients have musculoskeletal diseases, imbalances, disbalances, and so they need a fast solution, and we can offer really effective device with no side effects in I treat for more than 70 years, and I swear we had no real side effects. Some hematoma, some lasting pain, sometimes for some days. One thing is important at last. All over the years, you have 5, sometimes to 10%. They don't like shockwaves. It's a psychological problem. It's not personal, but we have some patients who say, please don't go away with your shockwaves, because if you use it the whole day, it's like a robotic thing to grab the applicator during the discussion and the anamnesis, and so we have 5 up to 10%. They don't like shockwaves.
Right. Okay. Yeah.
So it's important.
Yeah. Sure. Good to remember. I think. Look, we should always get back to the very real point that not everyone gets fixed with shockwave, and it has become a thing where people buy the machine and think that it's going to cure all things without that holistic approach, which is saying, look, actually, you need to do your exercises, you need to make sure your vitamin D status is good, you're sleeping well, stop eating all of the processed sugars as much as possible. But it is becoming, in some regards, it's becoming a which I've said on other podcasts, it's becoming a go-to machine, especially when you don't know what else to do. You put the machine on and hope for the best. The thing is that it works quite well on quite a lot of people, so people get carried away with it, but there's always going to be ones that doesn't work.
And I think in a modern therapeutic concept, it's necessary to use those devices, because if you call yourself a professional, I think you have to use this device. It's absolutely important for a modern and high-level orthopedic and manual therapy. It gives you another level in comparison to your colleagues. I think so. Yeah, because you have possibilities the others can't reach.
Yes, sure. Okay, Carlo, I think that's been brilliant, and we could probably carry on talking, knowing you from last week. We could have a pint and carry on, but we'll have another one, and it's been really fantastic, and we haven't had to press stop, pause, or anything else. It's been that's a record. Okay. So thank you very much, and I'm going to be saying goodbye now, and we'll see each other again. Thanks a lot for coming,
James. It was a pleasure.
Thank you.
See you soon. Bye.
Thank you. Bye.